Well, thanks very much for allowing me to come talk today. I think it's very important, so I'm happy to talk to you guys. And this is the same talk I actually give oncologists. So if you don't understand something, just ask, because this is also the same talk we give our patients. So we want, the whole goal of all this is to really have patients be really part of the team. And that's what we're going to talk about. I'm going to talk about our spine oncology team, and then we can talk about how it relates to breast cancer. I'm a little confined up here. I like to walk around, but we'll see if it works. And that video is a great segue, because it's amazing how many patients come to us and their oncologists haven't started them on those medicines. And so we see a lot of the results of those SREs and how to deal with them. So I encourage patients to be part of the team and ask their doctors about those drugs. Don't wait for the doctors to ask you about the drugs. And when I'm talking to patients, I always tell the patients, go talk to your doctor about this or that, the bisphosphonates. So what I'm going to talk about today, I get no money for anything, is basically how our team is set up and our algorithm for treating bone metastases. And it's going to be kind of a little more broad than just breast, but we can hone it down to breast and how breast cancer is different than some of the things that we see and how it fits into this algorithm. And part of this is developed because, the oncologists, we're physicians, oncologists are physicians, radiation oncologists are physicians, but we all are very differently trained and have a different understanding. And the patient has to understand all the parts of their treatment, and the physicians have to understand all the parts of all the different treatments. And so we started this program because we realized that the neurosurgeons didn't have any clue what the oncologists were treating or how the oncologists were treating patients, nor did the radiation oncologists understand what the surgeons were thinking. So we wanted everybody to kind of understand and know what everybody was thinking when they're treating a patient. So if everybody goes in and kind of understands and knows the algorithm, well, why are they doing A, B, and C, or in this case, we'll show you it's MNOP, then the patients will be better able to take part of their care. And the oncologists, it just makes it more seamless. And so there aren't that many integrated programs in the country. You have Sloan Kettering, MD Anderson, and a couple others are now trying to, this is obviously the way to go. And so all cancers are trying to go multidisciplinary. But we started one in Michigan, and you have to get buy-in from your colleagues. So Dan Spratt on the left here, is that your left? Yeah. And I started this when we came to Michigan in 2015. We met each other at orientation when we were faculty, and since then it's grown a lot. So it really is truly multidisciplinary of neurosurgeons, radiation oncologists, interventionalists, physical medicine and rehab, and then all the oncologists that deal with all the different parts. If you can't hear me when I'm walking around, just let me know. So before 2015, and we give this talk, normally I give it with Dan or with our other radiation oncologists. So there's a couple of slides that I don't know too much about that I'll be talking about, like the radiation stuff. But, before the spine program, the types of radiation they use were really low dose radiation, and that'll be called conventional radiation, and I'll describe what that is a little later. Or the surgeons were doing these enormously big surgeries. We didn't really involve physical medicine and rehab, which is a really important part in cancer care. We didn't use vertebroplasty, which I'll describe what that is later, but it's a very minimally invasive manner of fixing pain. And we didn't really have very good outcomes because of the just disparity. The treatment just wasn't unified. So we started the program in 2015. We got new linear accelerators in radiation oncology, and then spent about a year trying to make that work, because if you're giving the difference between conventional radiation and the radiation we're going to talk about a little is the precision and the lack of damage to the normal tissues. And so you really it has to be very QA'd a lot, because you only can have like a 1 or 2 millimeter of inaccuracy. So we spent about a year setting that up, and then a new way using myelograms to delineate the tissue better. And myelogram is when they stick a needle in your back and they inject dye, so then you can see the spinal canal. They used to just do it on MRIs, and we've published papers that show that that's probably not that accurate. So we went to this, and so we set that up. We hired people to help out, to kind of just bring the clinics together, because normally a patient would come in, they would go see their oncologist, they may go see a radiation oncologist, then they would go see the neurosurgeon if they needed it, or then they have to get set up. So now they kind of come in to see the oncologist, they get sent to see me, the radiation oncology, and the physical medicine rehab all kind of in the same day or the same appointment sometimes. and so we can all talk about it together. So we kind of have like a personal tumor board with everybody talking about everything together. In 2017, we wrote like an international guidelines on how to approach spine onc, which is kind of what we're going to talk about today, is a spine disease. So we can try and get other people to have the same conversation and talk the same way. We want everybody to have the same language, and that's part of the problem, is everyone's speaking differently, so no one really understands what anybody else is doing. We're getting the problem with one of the problems with the radiation that we're talking about is it's a lot of physics, it's a lot of math. It takes like a week to plan a radiation plan. So now then we just developed different methods to make the plans that now take hours to a day. So we're getting patients into radiation faster, so they don't have to wait for it. And then we're just hiring more people to help since we're getting so busy. This is our volume since we started. We're doing a lot more treatments. And the goal of this is to put myself out of business eventually. So our goal is to not have to operate on patients because radiation is pretty minimally invasive. It still can have complications, but it's a lot less complications than cutting someone open and doing surgery. So our goal is to kind of, as much as we can, to do more radiation, less surgery. Our surgical volume has almost doubled since I've been there as well. But I think our surgical volume per patient seen has at least gone in half. And I'll show you what that vertebroplasty is. That has increased a lot, which is just an outpatient procedure. So we do a lot different things. And we also we're also doing research because we know that we still have a lot of work to do. So we've also published a ton of stuff in the last 4 years on the basic science aspect, the translational science aspect, and different things that we see in the lab. And breast cancer is one of the things that we focus on. And so a little background, and that video covered some of that stuff. Bone mets in general are very common. And actually, if you get metastases of bone mets, a lot of those go to the spine. And in my lab, particularly, we're kind of researching why things go to the spine over other bones, what is different about the spine. But they go there, and it's a problem. It causes pain, like you said, these SREs, a decreased quality of life and mobility. And then you get this subset where it really becomes bad, and you get cord compression. And then you're left with neurologic deficits, things that are not recoverable, really, because the spinal cord doesn't really have a good recovery mechanism. So once you get stuff, it takes a really long time to recover. And that if you're looking at like a trauma patient with a spinal cord injury, they have the time to recover. In cancer, you're also, on top of that, you're getting chemotherapy or some other therapy and radiation therapy, which really also hinders that recovery time. So every time you get a spinal compression, it can be life-altering, especially for a cancer patient. It can interfere with their treatment, and if you need surgery, all that does is hold up your treatment. So that's really why we're focusing on this stuff. So a little bit of history. Obviously, this is in the 1980s. This is the life expectancy of a breast cancer patient in the 1980s after surgery, and there's a big study published in 1990. It was 13 months. So the treatments and everything this is like so different. I'll show you the new data as it is now, but it's really not that good. And what the treatment was really just palliative radiation at best, and radiation was done very differently. And this is what the slide the radiation oncologist would be giving, but he'd never even heard of the techniques of radiation that they'd been giving back then. They didn't have the precision that they have now. They didn't even use like what's called a simulator where they actually know where they're radiating. They just kind of put somebody stand in front of a beam and you just radiate everything. So it was really non-precise. And the duration, the responses didn't last very long. So they're really just treating pain at one point, and even that didn't work. So this is 8 gray, is a very low dose of radiation. But these are different papers, but the responses really wouldn't hold. So you're talking about a 2 to 4 week, 2-month response for pain. So I'm in pain, I get treated, but then in 2 months it comes back anyway. That's the same thing. And then local control, same thing. It didn't really have a problem. It didn't really do anything for local control. So we're talking 50% at 3 months, 18% at a year. And I guess if patients only live 13 months, that's pretty good. But it's not good enough. And this is the type of radiotherapy that they kind of gave. This is SBR. This is our external beam. It's hard that I can't see up there. But if you can see it. So basically this is a CAT scan. And if you can't hear me, I'll yell more. But this is a CAT scan. So you can see this is like an axial cut across this way. So So here's the front, the back. So basically the beam would start here and just go through. So you can see all the normal. This is like bowel up here. This is the spine, and this is normal tissue. So everything gets the same dose of radiation. And really what you hope, it's like old school chemotherapy. You just hope the cancer dies before you do. So here you hope that the normal tissue can tolerate that radiation, but the cancer can't tolerate that radiation. So, but if you have cancer that doesn't mind radiation, you have to go up, then the normal tissue will die before the cancer does. So that's the older version of radiation too. And surgery was so bad back then that no one did surgery, so they just did radiation. But then this study kind of changed for us, for neurosurgeons, looked at, well, radiation really sucks. Let's see if surgery plus radiation is better than radiation. And so then they had people that had spinal cord compression come in. They said, well, we'll do like a big surgery. So they did surgery, and they found that surgery plus radiation did really a lot better than just radiation. And that was in part because that was the type of radiation they were using. These patients they had to stop the trial after like 6 months, though. Surgery did so much better. So this was a great boon for my industry. I don't know how good it did for patients, but so we started doing surgery, and we thought, well, if the little surgery is good, a lot more surgery could be better. So then we started doing really big surgeries on patients. We would say, well, if we can get the tumor out, what's called en bloc, and basically we would just take out the entire spine of these patients. It would be like a 2-day surgery. The patients were in the hospital for about 4 months, and they did horrible. So so now we've kind of pulled back from that. We don't do that anymore. And now we're finding that, with newer chemotherapies and things, that patients are doing a lot better. This is survival of patients with spine mets, and this is 2008. So now breast cancer mets, those are in group 3, the blue on the top, they'd be living a lot longer. So now you're talking the median survival after getting bone mets here is in this one, it's, at least 2 years. But we see people out 5 years now. At least. But now we have to come up with different paradigms. We can't rely on just a little bit of radiation that's going to give you a 50% control rate at a year, or 50% at 3 months, 18% at a year, and 50% at 3 months. So these patients, you're living longer, so we need better treatments. And so then we came up with our whole algorithm, and that's really based on that the treatments have changed. So our surgeries have changed, and I'll go through some of the surgeries that we do now. The radiation has changed, and we'll show you what kind of radiation we have now. And we'll do it in the context of this algorithm. And so we did, obviously our algorithm still, if the prognosis of the patient isn't great, meaning that somebody only has 2 or 3 months to live, then a lot of the stuff we do isn't going to help the patient. So then that old school radiation probably is okay to give palliative medicine and give radiation and get someone out of pain. You don't have to do the high dose radiation. You don't have to do a surgery. So a lot of it comes back to that. But now, if people are living a year, 2 years, 5 years, you need things that are going to treat the patient for a durable fashion. So we came up with this algorithm, MNOP. It's really easy to remember, and we'll just go through each one. So this is why, if you're a patient, you're in my office, you understand kind of what things we think about, and it's listed MNOP in sequential order, but it's not really sequential. We have to just take in all 4 of these things into account when kind of coming together with a plan at the end with the patient. So, but these are the things we have to, it's like juggling 4 balls in the air at once. So we have to kind of juggle all these things to kind of come together with a plan. So M stands for mechanical, right? Mechanical stability. That video is talking about that it can cause a spine fracture, and it can cause tumor compression. So the fractures can cause instability. So what is instability of the spine? Well, when we asked that, nobody really knew what that meant. The oncologist definitely didn't know what it meant. What's an unstable spine? So we had to first come up with a way. So neurosurgeons and oncologists about 10 years ago, in 2011, so 8 years ago, but came up with a way of understanding instability and stability in oncology patients and cancer patients. So they came up with this thing called a SIN score. And this is not really like, yes, if it's this number, it's this. It was more of a way of speaking, so of having the same language, so that an ER doctor could look at a patient and look at this little checklist and say, this may be unstable. This I should call a neurosurgeon, or this is probably pretty stable spine. So you just kind of go down and look where it is and add up the points, and if it's really a high number of points, It's an unstable spine. If it's a really low number, it's probably pretty stable. And because in the past, we had a hard time talking to ER doctors, and they didn't understand what stability was. The oncologists didn't understand it, and so they would see patients with these fractures, and then they would never send them to anybody, and they wouldn't understand that, gee, that's a pretty unstable spine. And then this on the right is just something that, based on the stability, there's a lot of things we can do to treat pain or instability. So and that really will come back later in the end, saying, well, what are the goals of treatment? If the goals are to get stability of the spine, there's numerous things we can do. We can do what's called a vertebroplasty or a kyphoplasty. If somebody has just this fracture and it's just in the vertebral body, that's the bone in the front of the spine, then really all they need is cement just to kind of hone it up. So we use that for SIN scores that are what are called intermediate. So if they're kind of in the middle, the patient has a lot of pain. And breast cancer is one of the cancers that we could do a lot of vertebroplasties in, because breast cancer goes to the spine more than almost anywhere else, and it causes these fractures, and people have a lot of pain. So a lot of our patients are now just getting a lot of cement, where in the past they probably would have gotten a bigger surgery to stabilize the spine, but now we're finding that if it's just anterior bone disease, the cement does fine. And this is just an outpatient procedure that our interventionalists do, our neuroradiologists do. So they just come in, put cement in, and then you can go home the same day. And it really works quickly, and it works really well. And there's large studies that show that for mechanical fracture pain for cancer patients, that really helps. You don't need a big surgery. Other types of surgeries we do, again, we used to do those really big surgeries. The incision sometimes would be like that big on patient's back. So now we do something that's a lot smaller. Patients would have a lot of pain because when you go down to the spine, you have to take all the muscle off the spine. So we kind of do this thing, it's like a hybrid. We open the incision is still kind of the same size, but we only work on the area that needs to be worked on. If there's only a fracture and the vertebroplasty won't work, we can just do what's called percutaneous, meaning that we just open the skin and through the muscle fascia we throw screws. If the tumor needs to be resected, we just open the muscle fascia over the tumor and then take the tumor out. And if you guys have any questions while I'm talking, I'm happy to interrupt and answer them too, or you can just write them down and ask them at the end. So we can do more minimally invasive stuff. And now with cement, we're using it a lot more. I trained with 10 years ago I got out of training. We were still doing longer because cancer destroys the bone so much. We were doing a lot of really long constructs. If you think of biomechanics, we wanted to give somebody like basically titanium suspenders in the back to hold them up. So you need a long area to kind of hold the spine together. But now with cement, we're doing a lot smaller constructs. So we're putting just in screws like just right above and below the area that's affected by cancer, and then we're treating the cancer itself. So it's a lot less. So, and then we just do all this perk. So these are like, patients recover a lot faster. They go home in 2 days instead of like 8 days. They have a lot less muscle pain. So mechanical stability is kind of one of the more important things that we think about. And then we think about M, then we go to N, which to us is neurologic, either risk or compromise. So neurologic deficit, does the patient come in with like, I'm getting weak and I can't walk and it's been getting worse for the last 4 days? Or, gee, on the MRI, I can't even see the spinal cord. Or, am I at risk for getting a deficit if I have this? So this is just the types of pain involved. So if we talk to patients about pain and doctors about pain, trying to describe the pain, there's different types of pain. And so it's, we kind of try and get at that by asking specific questions. There's cancer pain, then there's mechanical pain. Cancer pain is something that happens at night mostly. So if you remember when you were a kid and you stubbed your toe and you wouldn't feel it all day, but then when you're trying to sleep, it would really hurt really bad. And that's because, like, same thing that happens with cancer. Cancer is it's kind of irritating, right? It's irritating to everybody's life, but it's irritating to your body. It releases a lot of inflammatory cytokines, and your body during the day makes a lot of steroids. But at night, your steroid level drops. And then you feel more inflammatory pain at night. So we ask patients, do you have more pain at night or when you get up and move around? So biologic pain is worse at night, but it gets better when you get up and move around because you stimulate your body and you make more steroids. Mechanical pain happens when you get up and move around, so it's the exact opposite. And so usually if you have a SRE or a bone met or something, it's probably a combination of both, but we have to figure out how much mechanical pain versus how much inflammatory pain you have. And then there's radicular pain too if the tumor is growing into what's called the foramen, which is where the nerves go out. then you're going to have radicular pain, which is like electric shock pain, like sticking your hand in a socket, shooting down an arm or a leg. And breast cancer is kind of a weird cancer because there's different types. So some cancers eat bone away. Breast does a little bit of both. Sometimes it eats bone, but sometimes it like pushes the bone and makes and builds bone. It's called blastic. So sometimes if it's a lytic lesion and it's pushing on a nerve, then you just treat the cancer and that pain will go away. But if it's a blastic lesion and it just expands the bone, you can treat the cancer, but that bone isn't going to go anywhere. So you'll still have the radicular pain even after you treat the cancer. Then you need actually like a surgery or something to kind of decompress the nerve from the bone that's grown into the nerve. So those are kind of important things to think about when you're thinking about types of pain. But when we talk about the neurologic risk, we talk about it in a way, a radiographic way, like on your MRI, like what does it look like? How at risk are you for developing a neurologic deficit? So if you don't have one. So we came up with a scoring system, somebody, Sloan Kettering, came up with this, and we've simplified it a little because if you're talking to an ER doctor at night or one of my residents, you don't want too many categories. And so they have like 7 or 8, but we just put it down to 4 so people could remember it. So this is a MRI, a magnetic resonance imaging. So and again, this is that axial slice. So here's your spinal cord right here, and there's water. The white surrounding it is spinal fluid. And so this is like a happy spinal cord. It's floating in the water. And you got to think of the spinal cord as like a cable floating in a water balloon. So that's basically what a spinal cord is. It just sits there, and the dura is the water balloon, and then there's water. The spinal fluid is all around it. So if you get bone disease here, that's fine because it's just in the bone. There's plenty of space between the bone and the spinal cord, so there's no compression. Here, there's the bone. It tends to grow out into the spinal canal, and then there's not a lot of space between the spinal cord and the tumor. But it doesn't invade ever. It just pushes in. So it respects that water balloon. It doesn't go into the water balloon. So there's always a normal plane under the water balloon. So if you took the tumor out, the water balloon will just expand again. And kind of every treatment we do now really relies on that expansion of the water balloon. And we can talk about it a little later about exactly why. And then here is like, you can't see, here's the spinal cord, and all this is tumor. So I'd say if you have that, you're probably at risk of something happening sooner than later. I mean, tumors grow slowly, and the spinal cord is kind of spongy, so it can accommodate compression until it can't, and then it's a quick deterioration, and then you're going to get symptoms. So you really worry about somebody like this getting paralyzed very quickly. And then this, I don't think I've seen too many of these without already having some kind of deficit. But the deficit people have, and a lot of physicians miss, is what's called myelopathy. And so, when I talk to physicians, I always say you really got to look at it. But they'll see a patient in the ER, and they'll say the patient is full strength, meaning that when I test their leg strength, when I test their foot strength, they can push against me and they look normal. But the patient says, I can't walk, I haven't walked in a week. But that they're not weak. So that's called myelopathy. And myelopathy is what's called a long track sign. It's the tracks on the back of the spinal cord they give off what's called proprioception, which is us knowing where our bodies are in space. Like, that's why I can touch my nose without looking at it, or, touch my, bring my leg up. And so if you have injury to that, you can't do that. So if I was proprioceptive deficit, I would come off here somewhere like this. So in the cerebellum, it's in the spinal cord. Yeah, you just can't do it. So that's really one of the things. And if you don't get a patient up to walk, you'd miss that a lot. So a lot of ER docs don't do that. They're examining a patient in a stretcher, and they just say they're fine. When really you could have this, and you could have severe myelopathy. And unfortunately, myelopathy does not recover very well. So we can do surgery, but those tracks don't get a lot of improvement. So unfortunately, we see a lot of patients who are still unable to walk even months after surgery because of the myelopathy. But we use this as kind of a language so that we can communicate, saying they have grade 0, grade 1, grade 2, grade 3. So I can talk to my radiation oncologist and say, well, it's got grade 1, can you radiate that? And they'll say, and look at, well, it's probably too much. I can't get enough dose to the tumor without dosing the cord. And so he goes back to that old, okay, how much dose can we give the tumor versus the normal tissue? So with the radiation that we want to do, we want to give the cord can only tolerate a certain amount of dose. So you want to give room, and a lot of everything we do was predicated on giving the cord enough room to give the tumor the full dose. So we got the M, we got the N. if they have people have severe neurological deficits, we probably have to go to surgery pretty quickly to decompress that. But there are some caveats, and breast is kind of one of them. So the oncology plays a big role in it. So there are things that are really, really responsive to radiation. That means that very low dose radiation will kill the tumor cells. And that's like lymphoma, multiple myeloma, seminoma, small cell, like in hours. So there's two things. It's how sensitive it is to radiation, how responsive. So there's some things that are sensitive, like prostate and breast are somewhat sensitive to radiation. Doesn't mean they're responsive. So it doesn't mean that they'll melt away in hours. So if you have a grade 2 compression and I radiate it, yes, if you have 5 months, that'll probably go away. But if it just swells a little bit, then you may be paralyzed. So you may not have the time for it to respond to the radiation. So we have these highly responsive and sensitive tumors. Then we have intermediate. And intermediate is kind of a catch-all. But then we have the unfavorable with some things that just, you need really, really, really high dose radiation for these tumors to die. But prostate, breast, we're moving a lot more things out of intermediate. This used to be a bigger category, but breast and prostate are still in it. But it's not all breast cancer, and so a lot of that we rely on the history. Did you have breast cancer before? Did it respond to radiation? How fast did it respond? So we don't really know yet all the molecular markers. We haven't found that like EGFR positive are more or less responsive to radiation. We don't know yet. So people are still looking into that, saying, are there molecular markers that can predict radiation response that we can then use, throw into our treatment algorithm? Because they would be very useful. So right now we kind of treat them all the same, but they're really not. So if we know that a patient had radiation and it didn't respond, then we kind of move it into the unfavorable category and are probably more aggressive with surgery and other interventions. And so this is our modern radiation approach. So on the left here, this is what's called SBRT, so stereotactic body radiotherapy, and this is external. We still use external beam a lot, although they do a better job than in the 1980s of doing it. But external beam is still, everything gets the same dose. And so if I radiate somebody, their bowel and GI system is getting that dose, their spinal cord is getting that dose, and the tumor is getting that dose. And again, for something like lymphoma, where that dose is very low, that's probably okay. For breast and prostate, it may be okay, it may not be. We don't know. Insurance companies think it's okay, because they're not always paying for SBRT. But we're trying to see if it's really okay. And I think as people live longer and survive more, and you're getting more re-irradiation issues where other tumors are coming back 5 years later, then you're really seeing where this fails, because the gut and you can't give. Once you give radiation, you can't keep giving it. There's just, we give it 3 to 5 times, but we're starting to see complications from that. So the more precise your radiation can be, the better it has to be. So this is SBRT. Instead of just standing in front of a beam and getting it through and everything getting the same, now you're lying on a table, the table's moving around, the beams are moving around. So all the beams are really small, but they all coalesce to give you a really precise radiation dose. And even here, the spinal cord, which is in the middle here, gets very small amounts of dose. There's still some dose all out here, but again, most of the dose, probably 95+%, really just goes to the tumor where you plant it. So then in 2-3 years, if something happens right next door on the next level, you can give that same dose and you're just re-irradiating the spinal cord to a minimal amount. So this has really changed our paradigm of how we treat spine mets in general and bone mets in general too. And a lot of this, I'm talking about the spine specifically, but we do the same thing in long bone mets, in femur and humerus mets and things like that, and pelvis and sacrum. So our goal is to give the spinal cord room, because that's what I care about, the spinal cord. I don't care about the gut too much, but we always want to save the gut too. But we want to give it enough room. So anything we do surgically goes to mechanically stabilize the patient in the spine, to then what is the best local control we can do. So we say, okay, if we do this, what is the local control of this? So this is with all tumors. Actually this is radio-resistant, not. So breast and prostate are not really in this group here. So this is conventional radiation, that's the external beam. This is low-dose SBRT, and this is normal SBRT. So SBRT, we try and give something called, we give 18 to 24 gray. So standard radiation, they'll tell you, is 30 gray. For breast cancer, a lot of patients will hear that, you're gonna get 30 gray, but it's spread out over a lot. Usually 3 gray, 10 treatments, so you're getting over 2 to 3 weeks. So this is 18 gray either in 1 dose or over 3 doses, 24 gray. And we found that, so this is with the most radio-resistant tumors, that's renal and sarcoma. So the ones that like don't blink it, like a nuclear bomb goes off, these things still at 2 years have an 85% local control rate. So that means that if you have like a metastases in your spine and you get SBRT, that 2 years later, that's probably gonna still be controlled with just radiation. So really we found that surgery really does nothing for control rates for that. Like I said, those big surgeries we did, people still had recurrences. So once you have metastatic disease, surgery is not what I call oncologic, meaning that there's really no point to go after something surgically that you're gonna get an advantage of, because we have such good radiation now that if we just radiate it, you're gonna have very good local control. So we put all that together and it's durable. So 18 months, 24 months, it's the same thing. So, and this is just also, these are my partner's slides. So look, going back to pain too. So when we looked at before, the pain control was really only for 2 months, maybe at most. So now we're seeing long-term pain improvements in the bone disease when we radiate. So that's why now we're using a lot of radiation for like femur mets or in the leg and everywhere. If patient has pain, you just radiate it. And it's pretty good that the pain will go away and that pain response will be durable, and as well as the local control. And so that 85% was for really, really resistant tumors. So for breast, we're seeing almost 100% control rate. And now we're out way more than 2 years because patients with breast cancer are living more than 2 years. So the high dose radiation really does a good job at controlling breast mets. And this is just shows the difference. So this is radiation sensitive pre-treatment. This is external beam. So breast does respond for the most part. So here's your totally squished spinal cord there. After radiation, it kind of just goes away. But now we're switching from external beam, not because the breast cancer needs needs a higher dose, but just to save the normal tissues around it. So SBRT doesn't mean higher dose. It just means more conformal radiation. And so it's normal. And then we should hear this sarcoma. So we did normal radiation to somebody did normal radiation to a sarcoma, and it doesn't really do much to it. So it does. So there you have to. This is not a good treatment for a higher resistant tumor because you can't give this tumor around here a high dose. So there you'd have to go in and do surgery and move the tumor away. And that's kind of what the paradigm does. And then P is kind of the patient, so or what the patient wants, and that's why it's multidisciplinary. And part of the team is obviously the patient. So we go over all this algorithm with the patient pretty much every time we see them, and how it fits into. So how does any treatment we do has to fit in with the chemotherapy that's being used? Are they on a break from chemo? Can we fit surgery in? How long do we have to delay chemotherapy? And what the risks of surgery are, because if we have a complication from surgery, like a wound infection or anything, that then delays the start of chemotherapy. So then you're talking, sometimes you have to take 2 weeks off, sometimes 4 weeks. You get a complication, you have to take the 2 months, 3 months off of chemotherapy, which some cancer patients cannot afford. So we have to really delve into with them and what their goals of care are. I mean, I've seen patients with only a couple months to live or less, but they're taking so much narcotics, they have so much pain that we do a surgery just to get them off narcotics. You know, you just do like a percutaneous screw fixation because they're a little unstable and they're in a lot of pain. And then now they can get off the narcotics so they can be awake for quality of life. So that's really a lot of the thing is how that, we always have to think about how our treatment fits in with the oncology treatment. So when the radiation oncologist and I sit and we see the patient, we go over, this is the best treatment for this one little area. Then we go broad and we talk to the oncologist and say, how does this treatment fit in with their systemic treatment? Because if we waste a month and a half treating the spine and your systemic disease advances, then we haven't done anybody any good. And this is kind of just an example of what we would do. So somebody comes in, they have a big tumor compressing here. You can't really radiate this, even if it was breast cancer. They had some neurologic deficit, then you would go in after surgery and then the cord would expand, and that water balloon would pop open, and now you see you have a nice. You can do the SBRT or the external beam, whatever you want, but the person is now not neurologically compromised, but it goes to doing the most minimal surgery that we can do. So everything we try and do is what's the smallest surgery I can do to get the goal of care, to get to the treatment. And if you go to a neurosurgeon who doesn't really know oncology, you're probably going to get a much bigger surgery. They'll do what they normally do, and then that'll just hold up treatment. So, and same thing. So this is an example of a radiation plan. So they would have surgery, and then that expands the water balloon, then you get a myelogram, and then you can treat everything there. So, all right. And same thing, just better pain control than everything else. All right. So I know that's a ton of information, but just remember, so mechanical stability, like neurologic compression or deficit. Do you have a deficit? Are you at risk for an impending deficit? That factors in for oncology. This is breast, so it's only one oncology. For me, we have to think about what the oncology is, what the histology is. But as we learn more about breast cancer, what's radiosensitive, what's radioresistant, and what molecular markers will drive which one, that'll come into play a little more as we subdivide deeper and deeper. Right now, we're kind of treating them as all radiosensitive, and then some people fail. We just don't know yet why they would fail because we don't have those markers to stratify them into radioresistance. And then what the patient needs and wants and the oncologist needs and wants. So, all right, so thank you. I'll take any questions about anything related to the bone mets in general or spine. I don't know much about bone mets outside the spine, but I'm happy to try and extrapolate.
Do you know anything about why with MBC it tends to go to the spine, the bones in the spine?
Yeah, no, that's what my lab is looking at. So we're looking at, there's some things that say like CXCR4 is a receptor that kind of hones things to the bone, and some breast cancers have that. So there's data on that. But we actually are looking more of what's different about the spine too. So we think that there's differences in that milieu, that soup microenvironment that just makes cancer grow better. So breast does hone to the bone. We think that some of those bone strengthening medicines will stop that because they stop once it gets there, the ability of it to grow. So that's why they're very important. So yeah, so there's a lot of research out in looking at why they go. They haven't figured it all out enough to figure out how to block it. Or we can change the microenvironment itself, and those bone changing things do that. So you can look at the cancer or the soup. So if we can make that environment a little more hostile for the cancer, so even if it goes there, it's not going to grow. And that's really what a lot of people are focusing on.
This might be a good question, but I'm wondering why certain cancers respond well and others just don't.
Radiation. Yeah, we don't know, and that's obviously a huge area of research. There's so many reasons why cancers do and don't respond. It could be they haven't, I don't think, come up with any molecular, like this is the gene, but maybe their DNA repair mechanisms are better. SBRT though works for everything because radiation. The low dose radiation, the way radiation works is it damages the cancer's DNA. And so when cancer, but it doesn't kill the cell, it relies on the cancer cell to kill itself. So normally you want to hit radiation on cells when they're dividing. So when the cell's dividing, it'll recognize that there's some damage, and then a lot of those cells will then kill themselves and go through what's called apoptosis. So the way SBRT works, the higher dose radiation, is it just gets rid of that whole cycle. It just destroys the cell. So it actually leads to something called necrosis. So the damage is different. And so probably, like breast, which is a little more sensitive, may have those mechanisms to go to the apoptosis pathway, where like renal cell and some of those don't have that. They just don't, they're dumb and they don't recognize that they're damaged. They just keep dividing anyway. So the way the high dose and low dose radiation work are very different. So their kill mechanism is very different. So kind of, I think, yeah. It's not like a nice, we can give a drug and inhibit that pathway, but it just goes, it's like a bazooka goes through it. So, any other questions?
What's the best type of scan to determine if you're radiocompromised? CT, MRI?
If you're, for the
yes.
MRI. So once we have someone in our clinic, and and they have any bone disease, then we see them every 4 to 6 months with full spine MRIs. In breast, it's a little, we're trying to figure out what that correct interval of surveillance is, because what we want to do is catch the metastases in the bone so we can radiate it before it grows into the spinal cord. Sarcoma grows really fast, so we have to really keep on top, because there's studies that show if you have a sarcoma spine met, within 3 months you're 80% likely to have another one. So we follow very closely, see if we can catch it, but sometimes we still can't catch it. Breast is a little more indolent. Sometimes we see patients, they have mets in basically every bone in their spine, so then what do you treat? There's where the bisphosphonates are very helpful, because they'll just kind of hold everything in check once it's there. And then we'll surveil every 4 to 6 months, but it really rely on the patients. Any new pain, any new back pain, any new anything, we'll get a new MRI. And because you don't want to just radiate the whole spine, even though there's disease everywhere, that's not a good thing to do. So then we'll just treat symptomatic lesions. But it's very important for the patient to be an advocate for themselves, because if you have cancer and go to the ER and you have back pain, and the standard of care is not to get an MRI. It is to get an MRI if you have cancer, but a lot of ER docs still don't do it. So you have to be an advocate. Know that if you go to the ER and you have new back pain, that you need a full spine MRI. So somebody can look into it and make sure we catch these things before they become a problem. So, yeah.
How do the biphosphonates work?
So bisphosphonates affect, you're going to challenge me here. There's 2 types of cells in the bone, osteoblasts and osteoclasts. So osteoblasts build bone, osteoclasts break them down and create a lot of, so cancer jumps in on this cycle, it's called the vicious cycle. And so they co-opt the osteoblast-osteoclast cycle to help them grow. So they knock down, they destroy the bone, and then they use the stuff for resources. So the bisphosphonates kind of stop that cycle. So they inhibit the osteoblasts, I think. One of the researchers here can probably tell me better, but if I'm mistaken, they inhibit the osteoblasts so that it just stops it. So it does stop the building of bone, but what it does practically is it makes your bone very sclerotic and hard. But it may make it a little brittle, I don't know, that might be one of the side effects of that. But it really stops the tumor from using that feedback cycle to grow. All right, so I think I'll be hanging out later. I think but anybody can come up and ask anything later. Thank you very much.
Thank you so much.
Oh, you're welcome.
I appreciate it.